This video is about Mycobacterium tuberculosis. If you're new to my channel, make sure to hit the subscribe button and the bell icon next to it so that you'll not miss out any of my upcoming videos and you can keep watching all my medical videos for free. Let's talk about the general properties of all Mycobacterium bacteria. All of them are acid fast, which means they can resist decolorization by adding acids. So this is what is the basis of acid fast staining, such as ZIEHL-NEELSEN staining or ZN staining, which has been done to diagnose Mycobacterium tuberculosis infections. The guanine plus cytosine content in the DNA of Mycobacterium species is about 60 to 70%. Most of the Mycobacterium bacteria are non-motile, non-sporing, non-capsulated, gram-positive rods. Here, they are actually weakly gram-positive. This is because the cell wall of the Mycobacterium bacteria are less permeable to gram stain, so they cannot be clearly made out on gram staining. That's why the gram staining method is not usually preferred for diagnosis of tuberculosis infection. Rather, we do acid-fast staining to diagnose tuberculosis infections. They are obligate aerobes, which means they need oxygen for their survival. Without oxygen, they won't be able to survive. Let's talk about the structure of the cell wall of Mycobacterium tuberculosis, which is unique compared to any other bacteria. Now, as you can see here, from inside out, the tuberculosis bacteria cell wall has cell membrane, peptidoglycan layer, arabinogalactan layer, mycolic acid, and mycocytes. Now, all these layers are important, but the most important of all these layer is actually the mycolic acid layer, arabinogalactan layer, and the peptidoglycan layer. These three layers are very important. The peptidoglycan layer confers rigidity and maintains the shape of the cell of the bacteria. The arabinogalactan layer is actually helping the bacteria to survive inside the macrophages. When I talk about pathogenesis, I'll explain about this in a bit more detail. But if you're listening it for the first time, it should evoke the interest in you, because this layer is helping the bacteria to survive within its own enemy, which is macrophages. So it is very special for the bacteria and interesting to study about. Now the next layer, mycolic acid layer. This mycolic acid layer is anchored to arabinogalactan layer, and it is kind of thick layer, and it makes the cell wall less permeable to various substances. So this makes it difficult for antibiotics to penetrate the bacteria and cause its effect. And and by doing so, it confers protective effect for the bacteria. Okay, and these are some of the important points regarding the structure of cell wall of Mycobacterium. And apart from that, it has got cytoplasm, in which it has got various antigens which are actually used for serological tests. As we all know, the most common route of spread of tuberculosis, the pulmonary tuberculosis, is by the respiratory aerosols generated when an infected person coughs. This is the most common route of spread of the tuberculosis infection. But although this is the most common, there are a few rarer routes of spread of infection, such as when we consume unpasteurized contaminated milk, which is infected with tuberculosis bacteria, such as bovine tuberculosis. Those are some of the rarer routes of spread of tuberculosis. But nowadays, since in most of the countries we get pasteurized milk, the incidence rates of this infection has come down. Now let's see about the most interesting part of this video, the pathogenesis. I've tried to oversimplify the pathogenesis in this video. This is just to give you a spark on what actually happens. And if you watch this, you'll get an idea. And after watching this, make sure to go and read a proper textbook to get further idea on what's going on. Okay, so let's start. First, we have these respiratory aerosols, which are produced when an infected person has coughed. Okay. So these aerosols are suspended in air, and it's interesting to see that these aerosols can remain suspended for minutes to hours in the air before sedimenting on the floor. And when a healthy person comes into contact with these respiratory aerosols, what happens is that they can accidentally breathe these aerosols inside them, and so the bacteria enters the upper respiratory tract of this person. The good thing is that our upper respiratory tract has got ciliary lining, which is very helpful in clearing these bacteria and abnormal antigens, as we all know, and that's what it actually does. So it tries to beat the bacteria out of the body by beating the cilia upwards, and unfortunately, some of the time, some of the bacteria, 5 to 10% of the bacteria which has entered the upper respiratory tract, can reach the alveoli, and they can reach the alveoli. As we all know that our alveoli has got numerous macrophages. These macrophages can detect the tuberculosis bacteria with the help of the complement receptors, and the complement receptors bind to the lipoarabinomannan, which is the thing which is present over the Mycobacterium tuberculosis bacteria. When these two binds, what happens is that with the help of various complements like C3b, what happens is that there will be phagocytosis of the bacteria inside the macrophage. So the macrophage will be phagocytosing the bacteria inside it. And what happens after this is actually very interesting. As I told you when I explained the structure of Mycobacterium tuberculosis bacteria, it has got a layer called arabinogalactan, which helps it in the which helps the bacteria to survive within the macrophages, right? Yeah. So like that, with the help of the lipoarabinomannan, which is present on the surface of the Mycobacterium tuberculosis bacteria, what it does is that it inhibits the fusion of the phagosome lysosome and prevent the formation of phagolysosome. Okay, and by doing so, it prevents the defense mechanism of the macrophage. The macrophage won't be able to destroy the bacteria. So what happens is that the bacteria will be living inside the macrophages without being killed. It does this by inhibiting the increase in intracellular calcium and inhibiting the increase in intracellular phosphatidylinositol 3 phosphate. By doing so, they prevent the fusion of phagosome and lysosome, preventing the formation of phagolysosome, and by doing so, they prevent their own destruction inside the macrophages, and they can live inside the macrophage and successfully replicate inside the macrophage. This is what is the pathogenesis of Mycobacterium tuberculosis in a nutshell. And if you dig further into this, you can find details on toll-like receptors too, and various other cytokines which are actually interesting to study about. I would suggest you to read Robbins for that. Robbins' pathology textbook gives very interesting details on the pathogenesis of tuberculosis. I suggest you to go through that. Now, what happens after that is that the macrophages activate the T helper cells. They will present the bacteria to T helper cells, and it will activate the T helper cells to the two subsets of T helper cells, namely T helper 1 and T helper 2 cells. T helper 1 cells are actually very helpful in case of TB. T helper 2 cells, as we all know, mostly is involved in humoral immunity, which is mediated by antibodies. And so, since Mycobacterium tuberculosis is mostly intracellular organism, well, antibodies are not of much significance in case of tuberculosis disease. So T helper 1 cells, which mediate cell-mediated immunity, are actually helpful in case of TB. The T helper 1 cells secrete various cytokines like interleukin 2, interferon gamma, and so many other cytokines, which activates further monocytes and macrophages. Now, they can carry out two types of response. One is macrophage activating response, and second is tissue damaging response. There should be a balance between these two. Normally, a macrophage activating response should be more, and tissue damaging response should be less for a successful outcome. Okay, so if the macrophage activating response is good, the person will be able to control the infection, and if the tissue damaging response is very less, the person will be able to come out of the disease with very less morbidity, okay, with very less fibrotic nodules and not much of lung damage. Okay, so there should be a balance between these two. Let's talk about macrophage activating response. In macrophage activating response, if the macrophages are successfully able to overcome the self-defense mechanism of the tuberculosis bacteria, they can successfully control the infection. So if the macrophages are working normally, and if the immunity of the person is actually good, we can see formation of something known as tubercles in the lungs of the patient. These tubercles are classified into hard tubercles and soft tubercles. If tubercles are forming, it is actually good. It actually means that the person has got immunity against tuberculosis and it's working well. Okay, so first the patient will develop hard tubercles. Hard tubercles are the one which is seen on the left. uh, it is composed of activated macrophages like epithelioid cells and giant cells, which are present in the center and surrounded by lymphocytes and fibroblasts. On the right side, you can see soft tubercle. This hard tubercle later gets converted to soft tubercle. As you can see here in the center of the hard tubercle, um, what happens is that particular the center area of the hard tubercle will undergo necrosis, which is caseous necrosis, where it forms a cheesy material and it forms soft tubercle. Okay, so the hard tubercle gets converted to soft tubercle, and this will be able to control the spread of the infection any further. Okay, and it will control the replication of the bacteria as well, because if the bacteria is contained within the necrotic area, there won't be oxygen supply to that area. So as we all know, Mycobacterium tuberculosis is a obligate aerobe. So if oxygen is not provided to it, it won't be able to live, and so it has to die. That is what happens as a result of macrophage activating response. I hope you understood the importance of macrophage activating response. The tissue damaging response will be more in cases where the macrophages are not so effective, and that happens in patients who are immunosuppressed or immunocompromised, and in patients like with various diseases like diabetes mellitus. Okay, so in these patients, there won't be adequate formation of tubercles. Instead, there will be excess activity of the bacteria and uncontrolled proliferation of the bacteria, and in these patients there will be excess lung damage, and there will be excessive spread of the infection to various parts of the body, leading to formation of disseminated tuberculosis. Now let us talk about the clinical manifestations of tuberculosis. First, the tuberculosis is classified into pulmonary TB and extrapulmonary TB. Pulmonary TB is the one which happens in lungs. It is further classified into primary TB and secondary TB, which is also known as post-primary TB. When a person comes into contact with tuberculosis bacteria for the first time, they develop primary pulmonary tuberculosis. Now, following primary pulmonary tuberculosis, three things can happen. The first thing is that the condition can resolve spontaneously. Now, this is what is going to happen in most of the cases, luckily, and that's why not all the people who are exposed to tuberculosis bacteria are going to develop tuberculosis infection. Most of it is going to resolve spontaneously because of our immunity. Uh, a significant proportion of the people will have latent tuberculosis. This means that the tuberculosis bacteria are not going to die, but they're going to stay dormant inside the person, and it's not going to cause any manifestations. This is actually not good, because this can later on undergo reactivation and cause disease at any point of time in that person's life. A third severe condition is known as primary progressive TB. Now, if the person's immunity is not able to hold back the infection, the person's going to have progressive disease. And this is a kind of severe disease causing severe tuberculosis, and this condition is known as primary progressive TB. Primary pulmonary TB usually involves the upper part of the lower lobe and lower part of the upper lobe, and it forms a classic lesion known as gone focus. Gone focus is nothing but the fibrotic nodular lesions which are formed in the lungs because of the immunological reaction with the tuberculosis bacteria. Okay, when the gone focus is when the gone focus is combined with the regional hilar lymphadenopathy, it is known as primary complex, which is also known as gone complex. Okay, so the gone focus combined with hilar lymphadenopathy is known as gone complex. Now hilar lymphadenopathy happens because the macrophages which are phagocytosing the bacteria in the gone focus region will spread to the regional hilar lymph nodes, and they form lesions in the lymph nodes, regional lymph nodes, also causing lymphadenopathy. And this is why the hilar lymphadenopathy happens. So when hilar lymphadenopathy is combined with gone focus, it is known as primary complex, which is also known as gone complex. The Ranke complex is the one which means the when the primary complex or the gone complex undergoes calcification, it leads to formation of Ranke complex. Okay. Now, primary pulmonary tuberculosis is usually not infectious, which means these people are not going to spread infection to other people around them in most of the cases, because they're not going to produce much of a cough with expectoration. So the rate of spread of infection is not common in case of primary pulmonary tuberculosis. Now, if a primary pulmonary tuberculosis is to cause much of manifestations, it usually occurs in adult children. Okay, if primary pulmonary tuberculosis is gonna cause manifestations, if it's gonna cause the disease per se, it's gonna cause in children because they have low immunity, and it also causes progressive disease in immunocompromised and immunosuppressed individuals like HIV patients mainly. Secondary pulmonary tuberculosis usually occurs following reactivation of latent tuberculosis, or if the person who already has primary pulmonary tuberculosis but the disease was in control gets exposed to further bacteria frequently, and so the disease gets severe. Okay, so that is what is called as secondary pulmonary tuberculosis, which is also known as post-primary pulmonary TB. The most commonly involved areas in case of secondary pulmonary TB are apical and posterior segments of the upper lobes where oxygen tension is relatively high. And here we have a complex which is similar to Ghon's complex, but this is present in the upper lobes. Okay, so upper lobes of the lungs. This focus is known as Asman focus, and we have another focus in secondary pulmonary TB, which is known as Simon focus. This is usually seen in the apex of the lungs. This usually forms because forms by hematogenous spread of tuberculosis bacteria from different parts of the body to the apex of the lungs. Okay, for example, if the person has TB elsewhere in the body, and if it's going to spread by hematogenous route, it spreads to the apex of the lungs, causing lesions there, and this lesion is called as Simon focus. Secondary pulmonary tuberculosis is usually common in adults. Secondary pulmonary tuberculosis is infectious because these patients will have cavitary lesions and excessive production of cough with expectoration, which is going to contain so much of tuberculous bacilli, and it's going to spread the infection to the nearby people, the contacts, the susceptible contacts especially. So secondary pulmonary tuberculosis is infectious. Now, if tuberculosis happens in any other site than the lungs, it is known as extrapulmonary TB, and can involve the lymph nodes, the pleura, the upper airways, the genital tract, the skeletal system, central nervous system, gastrointestinal tract, the pericardium, the skin, leading to scrophaloderma and lupus vulgaris. And it can also cause miliary tuberculosis, which is a form of disseminated tuberculosis. Now, lab diagnosis. First of all, we need to collect specimen. In pulmonary tuberculosis, the specimen is sputum, as we all know. But in the case of extrapulmonary tuberculosis, such as TB lymphadenitis, the pleural TB, sputum is not going to produce much of results. Okay, so we need to take specific specimen. For example, in pleural TB, we need pleural fluid aspirate. So in TB meningitis, we need CSF. Okay, CSF fluid. So the specimen varies based on the organ which is involved. Okay, when we collect sputum, we need to do a procedure known as a decontamination. This is because, in addition to tuberculosis bacteria, the specimen will be contaminated with so many other bacteria. So we need to decontaminate the specimen to remove the unnecessary bacteria so that we can be focused on the tuberculosis bacteria only. And the preferred medium which is used for this purpose is Petrov medium, which contains 4% sodium hydroxide. So what we are doing here is that equal volumes of sputum and 4% sodium hydroxide are mixed, centrifuged, and then the sediment is taken and it's mixed with 3% hydrochloric acid. This procedure will help us to decontaminate the sputum specimen, and then we can use it for various lab procedures. Now, ZIEHL-NEELSEN staining is an acid-fast staining procedure which is very helpful and very sensitive for diagnosis of tuberculosis, and it is most commonly done everywhere in the world. And it actually, the procedure, the principle, the steps, everything is actually important. And I think I'll make a separate video on that, explaining all the aspects of it, so that it will not take much of time from this video. There are other staining procedures like Kinyon cold acid fast staining or phenol technique. Kinyon cold acid fast staining, as you can see here, this name has got the word cold in it. This is because in the the ZIEHL-NEELSEN staining technique, we use heat in one of the steps, whereas in Kinyon acid fast staining we do not use heat in this. We do not use heat in any of the steps, so that's why it is known as cold acid fast staining. Armin phenol technique is a fluorescent staining technique, and it is a relatively less time consuming technique, and so it's a fluorescent microscopy technique, and it's very commonly used these days. The culture techniques, although very specific and although very sensitive, it is very time consuming, and it takes about 6 to 8 weeks to get results, and that's why they're not so commonly used these days. The classic culture media which comes to our mind when we think about culture for tuberculosis is the LJ medium, which is Lowenstein-Jensen medium. It contains egg, mineral salt solution, asparagine, malachite green. The colonies which are found on the LJ medium are described as rough, tough, and buff-colored colonies. This is a more sensitive method for diagnosis of tuberculosis bacteria, and the advantage is that it detects only viable bacilli. As we all know, in microscopy we can see all the bacteria which are present in the specimen. It can also include the dead bacteria which are present in the specimen, but in case of culture, only viable bacilli can grow and produce colonies in the culture medium. So if we detect something in the culture medium, it actually indicates viable bacilli. So the culture methods are helpful in detecting the viable bacilli and not the dead bacilli. So that is one of the advantage. The main disadvantage is it is time consuming. It takes about 6 to 8 weeks for the results. There are some automated culture methods like BACTEC, MGIT, which is Mycobacterium growth indicator tube. These techniques takes relatively less time compared to the normal culture methods. Now, the most commonly used and very specific and sensitive test for diagnosis of tuberculosis these days is the Gene Expert, also known as the CBNAT, which is cartridge-based nucleic acid amplification tests. The advantage is that it detects tuberculosis bacteria in the given specimen, and in doing along with that, it also detects the sensitivity status of the bacteria to one of the first line drug in treatment of tuberculosis, which is rifampicin. Okay, so it does two things in one go, and it is relatively less time consuming. It gives the results in very less time compared to any other method. So it is one of the most used and trusted methods for diagnosis of tuberculosis these days. In extrapulmonary tuberculosis, sputum is not going to be a helpful specimen, as I've told you already. So we're going to be taking samples based on which organ is involved. Okay, so I've given some specific findings which are seen in extrapulmonary TB. In pleural tuberculosis, we take pleural fluid aspirate, and in that you can see elevated adenosine deaminase enzyme levels, and interferon gamma levels. In tuberculous meningitis, we take CSF specimen. In that, you can see cobweb coagulum formation. Okay, so these are some characteristic findings in some extrapulmonary tuberculosis conditions. Uh, Diagnosis of latent tuberculosis. As I've told you already, latent tuberculosis is the one in which the tuberculosis bacteria are dormant in the body and they're not causing any manifestations. If you want to detect the latent tuberculosis, we can use two types of tests. One test is the tuberculin test, which is Manto test. The second one is interferon gamma release assay. Manto test is the one in which we inject the tuberculin bacteria, the protein derivatives intradermally in a person, and then we wait for 48 to 72 hours, and after that we observe for the induration which is formed in the site of injection of site of inoculation of the bacteria in the skin. If the induration is more than 10 millimeter, it is considered as positive, and if the size is less than 5 millimeter, it is considered as negative. But in certain cases, like in HIV patients, if the size of induration is just 5 millimeter, we consider it as positive. That's about Manto test. Interferon gamma release assay is not is used in areas where tuberculosis is not endemic. Okay, so it can be used in those areas, but in countries like India where tuberculosis is endemic, interferon gamma release assay is not a reliable test, and it is not commonly done in countries where tuberculosis is endemic. So we came to the end of this video. I hope you understood something about tuberculosis with in this video. So if you didn't understand any of the thing which I've told in this video, make sure to watch the video again. And if you have any other doubts, make sure to put it in the comment section below. I'll get back to you very soon, and I'll try to solve many of your doubts. And make sure to follow me on Instagram, Facebook, and if you like my video, support my channel. Consider supporting my channel on patreon.com/medvidsmadesimple, and I'll see you guys in my next video. Thank you for watching.